Hello, and welcome to a KidConfident webcast by myself, Derek Huffadine. I'm a paediatric emergency medicine registrar at Nottingham, UK, and with me I have...
I'm Caroline Dorsett. I'm a children's palliative care nurse specialist. So I'm the lead nurse for children's palliative care and medical practice at Nottingham Children's Hospital, and also involved in education around children's palliative care in the East Midlands region.
It's great to have you here, Caroline. We're going to talk to you a little bit about how to approach an emergency call to a child with a life-limiting condition, and particularly around advanced care plans. So thanks very much for just taking some time, and we'll talk about specifically what life-limiting conditions are, why advanced care plans are around and what you may find in them, and then we're going to have some case studies to talk about how you may approach different situations. This is obviously a difficult and potentially emotionally provoking topic, so just want to give yourself some time and to make sure that you look after yourself. So to kick off, Caroline, I just wanted to get you to talk about what life-limiting conditions are and how what sort of children are we talking about when we talk about life-limiting conditions?
So it's quite a big group. We know it's an ever-growing group. There's some research that is repeated sort of every 8 to 10 years in the UK. Comes out of the University of York, which shows that the number of children living with life-limiting conditions is growing almost year by year. And those of us working in paediatrics probably just feel that instinctively. We are caring for more children with medical complexity. We see the growth and the need of growth for children's palliative care services. And this group of children often has more attendances in hospital, more 999 calls and longer stays in hospital. They're still often lying in critical care units, even though we may recognise that they're not going to get better despite critical care. And this group of children are difficult to look after, and they make everyone very nervous. People often don't feel they have the competence or the competence to care for them. In some ways, it's quite a broad spectrum of children that might fit into this group and certainly span the whole childhood age group. In fact, some palliative care planning might even start even when the child's in utero, with the sort of advances in scanning technology and genetic testing. So I suppose the group of children that people sometimes think of when thinking about palliative care are children for whom they have a diagnosis which we know to be fatal in child. Some of the fatal trisomies, some metabolic and mitochondrial conditions, when there's more than one organ involved, and we know that child won't be a candidate for a transplant. So from diagnosis, those children will recognise that they have a short life. And then also there's the group of children where we may try to cure. We will make attempts to make that child better, but over time it becomes clear that that's not going to work. Perhaps the burden of treatment outweighs any advantage the child's getting from it, or the side effects are that themselves become life-limiting. So I guess that's thinking about some of the cancers. Some of the metabolic diseases may have a degree of control initially, but that control may not be maintained, and we worry that child will not survive childhood. And then I think we know from this research from York that the largest, greatest group represented in the children with life-limiting illness in the UK is children with complex neurodisability, congenital conditions and neurological problems. So that might be children who are living with the complications of extreme prematurity, might be children living with a brain injury secondary to brain trauma, or with profound hypoxic ischemic encephalopathy, for example. And I think those children are quite complicated to prognosticate for. They may not necessarily have a prognosis per se attached to it. So we know a child born with X syndrome may have, or syndrome X, I should say, because there might be an X syndrome. Syndrome X, we know, usually live to 3 years. Sure. But for example, a child who we know is likely to have very complicated profound cerebral palsy, we might not have a prognosis, but we know there are elements of the condition that mean they may not survive childhood. perhaps because of chest infections or seizures. And we know for those children, their medical complexity means that they're much more than the sum of their parts, and treatments of the seizures may make their chest worse, but we can't not treat the seizures. So that group of children, we may not talk about having life-limiting conditions, but certainly life-threatening elements, and that may evolve as the child gets older. So that would be another. We know these children are living all over the UK, and of course globally as well. And we know that social deprivation is overrepresented in children with this condition, these set of conditions.
Okay, so we're basically saying that, like, you can have a life-limiting condition like straight from being born and have a very short life, or have a condition that you may well get through to adulthood with. And it's really heterogeneous, isn't it? Lots of different stuff in there.
I think you can live incredibly well with a life-limiting condition. You know, lots of the children that I look after are attending school day to day, are, you know, involved in childhood, participating in life. I try to talk about that much more than quality of life, because that's such a subjective. But sometimes really good palliative care can go alongside active care, and that's okay too. We know that looking at all childhood deaths, that certainly in the UK, that the majority of children who die in childhood die in the first year of life, and lots of these children we're talking about will have a start in the neonatal unit. But equally, as you say, the other side of the childhood spectrum, that more and more of this group of children are transitioning to adult services, and that's a whole new challenge for us, because these services just don't exist in adults yet, because medical technology is meaning these children live for longer, but not always living better. And I think that's where good quality children's palliative care comes in.
I suppose it's just sort of that, like you're saying, these children have probably more contact with the ambulance service than your average child. Yeah, they've got more complicated needs. They may need oxygen when they come in. They may have equipment they need to take with them. It's easy to go in the car.
Yeah.
So we probably see disproportionately more of these children. So I just thought it would be nice when we turn up at the door to have a plan of what to do. So
they can be a bit scary, can't they?
They can.
Yeah.
And just sort of having that sort of background information, but more importantly, if you get called in a stressful emergency situation, what's expected of the team that turn up. And we say we're going to talk about advanced care plans. So tell me a bit about what advanced care plans are.
So we use the phrase advanced care plan, but we can also use emergency care plans. Medical All About Me's, regionally here, locally, we sometimes call them personal resuscitation plans. So there are a document that record what's the best medical interest decisions for this child. It's not a legal document. It carries the same sort of weight as a care plan or a thorough clinic letter. And it should be written by the medical team and nursing team that know that child well, with the involvement of the child if they're able, the young person, but with the involvement of their parents as well. We're not asking parents to make the decisions. I think that's something I always try to be really clear about. I can't bear the thought of parents thinking these impossible decisions are left on their shoulders, but equally we want the parents to be alongside us. We want them to understand why we're making these plans, and they want us to agree that it is right for the child. This is not within the scope for a talk, but you know, anyone that reads the paper or listens to the news will know there have been times, particularly mounting in the last couple of years, where there have been some legal challenges to these sorts of documents. And that obviously slightly changed the nature of them, but I would describe them as being a record of a difficult conversation, which describes best medical interests for that child or young person, written by the team that know them best on their best day and their worst day.
Okay, so different from an adult do not resuscitate order. I mean, some of them have got respect forms in them and things. So what you talked about there being different sorts of types of these forms. What in general, what would you expect to find in there? I'm getting some information about the child's the demographics? What other
So
stuff?
there is a national document, and I think increasingly in the UK, most areas are moving over to that national document, which I'm sure will be very helpful for paramedics covering big geographical areas, knowing exactly what the document's going to look like.
Sure.
But what I think, if we describe a best practice document, initially it would be some demographics about that child, perhaps who they live with. Then there'll be some description of why are we writing that plan. That's not just the diagnosis, but how does that diagnosis impact that child to
Sure.
make them potentially need some different, more bespoke care than another child. We'd want it to have some non-medical information too. So who are the important people to this child? What would be their wishes and choices if they were really poorly? That might be spiritual, religious, cultural type information. What makes them happy, you know, even perhaps choices about where they'd like to be for their end of life care. And I know that sometimes I've heard paramedics like be slightly frustrated about that, like, oh, it's just reams of information to find. But I suppose it's important to note that one part of this document is about that instruction to paramedics, should 999 be called, but it has lots of other uses too. Certainly it's really important to me that when a family looks at that document, they recognise their child in it, and they recognise their child as a person and not just around the diagnosis or a sort of tick box exercise. I suppose the important bits of medical information, there'd be the urgent emergency scenario. I used to call it the 999 bit, but actually for some of these plans, it won't include calling 999. It will be around holding and cuddling and comforting that child in their last moments. But for lots of plans we write, 999 will be part of that. And then that should be a clear description of what you should do if the child stops breathing or you fear their peri-arrest. So that would be one part. And in the national document, that's found at the back. So you can flip the document over and it should be very clearly stated there what you're going to do in that scenario. And the national document also has the respect document attached to it, which lots of people will be more familiar from the adult world as well.
Right. I think we've got a part of this. We will be attaching that national document with a pretend child documented through it, so you'll be able to have a look at it. This is the logo for the national document, and even if in your area you're using, or the people are using, a different document, the information in it is pretty much the same. I think one thing that that sometimes is useful as well is sort of like having emergency contacts, hospice numbers, all the different teams involved. But that's difficult, isn't it, around coverage and hours of work and things. But in some areas there will be more out of hours provision than others.
So NICE guidance and kind of national service specification is that all children with a life-limiting illness should have access to a 24/7, certainly medical contact advice line, but also end of life they're able to access 24/7 nursing wherever they are. We know that it's a bit of a postcode lottery and that provision isn't universal, sadly. So we'd hope that each plan has a 24/7 number on it, and that might be the local hospice, for example, might be a palliative care support line. But certainly there should be some details about who are the team around this child that will help with decision making and who have written this document.
Great, thank you. So have a look next to this webinar for a icon like this, and it will take you through to the documents for you to look through. We're now going to move on to some case studies and to get your brain thinking about what you would do in situations that you could be faced with. Again, these are completely made up, but are based on, you know, Caroline's long experience of doing this job. So our first case is a 14-year-old male who has the family have called 999. We know that he has cerebral palsy on the job information and that his complaint is being short of breath. That's all you have when you set off, and you are updated on route that the ambulance control will have an alert on him to say that he has an advanced care plan in place, but you have no further information. So I just want you to stop and think. I know something so I used to be a paramedic before I was a doctor, and one thing that I would do is to think about how I'm going to prepare myself to walk into that house. What equipment am I going to need? What bags to carry? What's likely to happen? What sort of cycle, go through stepwise in my head about what I may have to prepare for mentally. So I just want you to do that just for a second for this child, with the information that you have, which is limited, obviously. So as you get there, you walk into the front room and you're immediately faced by a front room taken over by Alex. He's in a hospital bed with an oxygen mask on. He's weakly coughing, and he looks distressed. He's pale, he's sweaty, he's grimacing in pain. His limbs are stiff and tightly set in contractures. Overall, he looks like he's dying. There's a hoist in the way, there's a bespoke electric wheelchair, medical stuff is everywhere. You think, how am I going to get this person out? Mum comes up to you and thanks you warmly and explains that he's had respiratory physiotherapy this morning. He's been having his saline nebulizers, and he's using his oxygen that he only requires when he's unwell, but he's needing that at the moment. And she gives you an advanced care plan folder, but tells you off the bat that it says he should have everything with no limitations. You go up to Alex and you put the saturation monitor on. He looks like he's working hard. His saturations are 81 and 2 litres of oxygen. He has a weak, wet standing cough, and he looks like he's struggling. So I want you to stop and think about where are you going to go with Alex? What are you going to do? Does his advanced care plan mirror what you have in front of you? So Caroline, that's like a tricky situation where you might feel they've got an advanced care plan, but that's not helping you. So what would you do in that circumstance if you can put yourself in a crew's mindset?
I think you have to follow the plan. And I think it's this mum has obviously handed you the plan because that's what she wants to happen. Hopefully, if it's a well-written plan, as well as that 999 emergency plan, there'll also be some plans for gradual deterioration. And actually, some of those we might, when we're writing the plan, preempt what are the areas the child might deteriorate in, and in this case, respiratory. So might be seeing what are the suggestions on that gradual deterioration. I suspect that this mum will have already followed a lot of those already, and I think that's something that I imagine be quite difficult, because when you go out to a medically complex child, they may look absolutely clapped out and there may be a frustration, why weren't you called earlier? And I suspect that those parents, that physio, have done so much already to try and keep that child at home, that by the time you get there, there are not a lot of things left to do. You mentioned, Derek, that as a paramedic, it might seem odd. Why have we written this plan if we're asking them to do everything that any other child? And I'd never thought of it like that, but I suppose that's a little bit different from adults, isn't it? That what we're trying to do is say, we're really worried about in the future, this child is more likely to die or have a catastrophic event than another child, and what should we do? At that point, when you first start introducing the advanced care plan, it might be that it is in this child's best medical interest. They may have never been to PICU before. You're seeing this child on their absolute worst day. You can imagine or get an idea from the house what they're every day, but actually these plans are written by the professionals that know them well and might think that there's a good chance, or a very good chance, they'll survive a PICU admission, and that we should reverse the reversible because their underlying condition and day-to-day is good and they're doing well. Yeah. And the reason we write them is, we could think of it like a warning shot or a red flag. We're saying early on to this family, we are worried that at some point these things might not work. We should hope for the best. We should hope that we will be able to get on top of this chest infection, but what's the plan if we can't? I think if you've had that early conversation about your worries with this child, but at that point you're saying, but I, you know, at the moment I think we should do everything, then later on down the line, when perhaps Alex has had multiple PICU admissions, his life is less good in between them, then you can take the family on the journey with you. Remember 6 months ago we thought it was absolutely right to try everything. I'm worried that's not in their best interest. And as we said, the advanced care plan doesn't only record an emergency scenario, it's also a really good document to look at other things a family might do, an emergency feed plan, for example, or a symptom management plan. So there are lots of reasons to do that advanced care planning early. And I suppose there might be a scenario where you go to Alex and there isn't an advanced care plan at all.
Sure.
I suspect that's quite difficult. Why has no one thought about that? I think there are lots of reasons for that, not least what we've already touched on is the fragility of palliative care services nationally. So this child may not yet have been in contact with someone who's competent to write an advanced care plan. Even as professionals, these discussions about a child dying in childhood are so difficult. So I think sometimes we avoid them. Perhaps we don't feel we have the competence to open those conversations with families. Families might be doing a really good job at blocking them and, you know, bring a sibling to clinic each time to make sure you definitely don't talk about it. But I think what I do know is as hard as it is to have those discussions, it's even harder to, or it's even crueler to not have them and then leave the family in this kind of scenario where death at this point is a likely option for Alex, isn't it? And no one's ever discussed it with them before. That takes away their opportunity to make decisions and have choices and build memories. So that early introduction of the advanced care plan, even if it states this child should have the same treatment as every other child, is.
I suppose that, yeah, it's that sort of feeling of going to a child who sounds like they're unwell with an advanced care plan, and your preconceptions maybe that there's going to be some altered treatment for them, and just being mindful of that if it's for everything, that's fine, and there's reasons for all that.
Yeah. And that some, you know, even with the most comprehensive care plan, we may not have mitigated for every circumstance.
Sure. What do you mean?
I think when we spoke to some paramedics, one of them made a really good point that as a paramedic, you're turning up as a totally fresh person that the parents have never made. And actually, a reason to get a child to hospital is for them to decision make with people the family trust and know really well.
Sure.
And, you know, I think it's very difficult to do things with a child you may not feel is in that child's best, but if the plan is there, it's to follow it. And I think, you know, even going to critical care doesn't have to mean a long, extended, prolonged, you know, but it does mean giving a chance to reverse reversible, and that's obviously felt to be right for this child with a full ACP, and giving a chance for the family to discuss these really difficult decisions with the team.
That's great, thank you, Caroline. So our next case is a 8-year-old girl. It's another 999 call, and the information is that she's blue and she's got a reduced level of consciousness. And on the way, you are told, what do you know, that she's got an advanced care plan. You're also told by the dispatcher, for more information from the call, that you were told that this child is not for hospital care. So an 8-year-old girl who's cyanosed and blue with a reduced level of consciousness would make me worry. Let's find out some more about her. So she's you drive up to the address, and there is a grandmother standing on the pavement, waving her arms, making sure you know where to go. She gets you out of the cab and takes you by the arm up into an upstairs bedroom, and she's shouting and pleading with you to save her granddaughter, Darcy. Dad's by the side of Darcy, and he's cuddling her. Darcy looks small, so she looks about 4 years of age rather than the 8-year-old that you know that she is. She looks cyanosed centrally, and she looks dusky generally all around. Dad tells you that she was born with a complex cardiac structural problem. She's had many operations in her life, but about a year ago, the surgeons and the cardiologists told them that there was nothing more that could be done, and that the last year she's had increasing amounts of palliative care input, and they've been coming every day for the last week as she's been getting worse. You asked, does she have a plan? Dad passes you a folder, but she says, just do everything, please, just save her. It's her birthday next week. I just wanted to see her birthday. And you're left opening an advanced care plan, which clearly tells you that this child, and the conversations that have been had, was for this child to die at home with palliative care input. So where do we go from here? What do we do? We've already talked about sort of it not being a legal document, but you know, these are very incongruous sort of information for us to deal with and walk into, isn't it? With a clearly a sick child with probably, I mean, it sounds like that this could quite easily be an irreversible problem. Is that fair, Caroline?
The PRP describes an irreversible, the ATP describes an irreversible, and it describes parents who, in a non-emergent situation, when they've been calmly discussing this, have felt that home was the right place to be. Assuming the daily palliative care visits have, I know a question I'd be asking is home still right to be? So it sounds like in the build-up, it's not like you've come to this family and they haven't had any contact with health professionals for 6 months, you know, in the build-up to this. So my sense has been we've arrived with family who are just totally panicked. Emotional times of the year like birthdays and Christmas just add this heighten to this already desperate situation. And I think we've said the PRP, the ATP is not a legal document, and ultimately if the family are screaming at you to do something, we don't want to leave a paramedic in a situation where they have a decision making.
Yeah.
You might have to. I think the bravery and the courage of the professional here comes around that sort of compassionate questioning of the family. I've read the plan and I can see that when you talk to Katie, your palliative care nurse, that home is the right place to be. I have to tell you, I'm really worried that if we put Darcy in the ambulance, she's going to die there. We're not going to get to hospital. And I'm really worried that wouldn't be right for you. I like a communication device one of my colleagues taught me, which is wish, worry, wonder. It can be used in actually lots of scenarios, but in here you could say, I wish that I could make her better, and I wish we could get to her birthday, but I'm really worried that if we start doing intervention, it could be very painful and distressing for Darcy and it won't make her better. And I wonder if we spend some time with you making her comfortable, whether staying at home is the right thing to do. Now, while you're having this conversation, your colleague, if you've hopefully arrived in twos, can be setting up some oximetry monitoring, you know, doing it, because it's very hard to have a parent shout at you to do something. And ultimately, if they continue to say, we need to go to hospital, that's what you need to do. Obviously, hope you have a parent in the back with them. We put the granny in here, haven't we, to talk about parental responsibility. Sometimes parents will have been really on board with a decision to stay at home, but a grandparent or an older sister or, you know, an auntie or uncle or a next door neighbour who's just popped in to sit there for 10 minutes might not be competent or on board or agree with the plan. And they may have called 999, but it is incredibly important to remember that it's the person with parental responsibility. That in that scenario where granny's babysitting, it might be kind and appropriate to bag the child until parents come back, or to agree to take them to hospital and parents meet them at hospital. It may be that they do fly in the ambulance, but what's important is you've had that honest and open conversation with the family. Hopefully there'll be a contact on the advanced care plan of their palliative care team, and you can call them and hand the phone over to the parents, because as we said in the first decision, parents will want to make, well, that's what we want for parents, that they believe decision making has happened with trusted professionals who know their child well. So hopefully then that contact bit on the PRP remains.
And I suppose it's just important to say that whatever you do, you know, you shouldn't feel that you've made the wrong decision, because actually these conversations can happen again when you turn up to a hospital with the child, or these are very difficult, they're very difficult situation conversations.
Actually, I've done some really, sounds like I'm being myself, there have been some really good palliative care done from an ED. You know, we get to ED and we can call the hospice and say, we think if we put some high flow on to get to the local hospice, we'll be able to get there. Is that the right thing to do? She very much said, we just don't want to move them again. And, you know, we can make a child find out what are the things that are important about home. Can we bring those things from home to the, sometimes it's the dog and sometimes it's the sibling and sometimes it's the man, you know. But again, that compassionate curiosity, asking families what's important to them. But sometimes, you know, if the family are shouting, then we have to listen to that voice. And we cannot make, in the most perfect plan or perfect pressure in the world, we can't make this okay for families, because even an expected death, it is absolutely devastating. Of course it is. You know, you may not know the wave, you may know the wave's coming, but the wave is no less powerful. And so we can only sit with being good enough and being kind to ourselves and saying we listened to what the family wanted in that moment, but we raised with them our worries and our concerns.
Thank you, Caroline. So I wanted to take a breath. We're doing our last case study. These aren't
More cheerful though, does it?
It doesn't. So you clear from a small emergency department, which is not in your area. You're near the end of your shift. You're hoping you can get back for an on-time finish, but oh no, bing, there we go. A 2-year-old cardiac arrest comes through. Off we go. On the way, we get a radio message to say that this is a palliative care patient with an advanced care plan. We know that they have a brain tumour. CPR is not happening because further information has come that dad still thinks is alive but not breathing very much. Oh dear, what a shift. Again, a horrible situation to be faced with. Again, sort of thinking about what are you going to do? Are you going to be walking into a full resuscitation? Are you going to be providing comfort care? It's one of those one of those situations where it's extreme, isn't it? And having to prepare for that emotionally is difficult.
What's going to be behind the door?
Yeah. So you go up to Billy's bedroom and his mum and dad are by his side. They're both looking incredibly scared and they ask you, what should we do? You look at Billy, he's unconscious. His breathing is irregular with a rate of around 6 breaths per minute, and it's a gasping pattern. You can feel a pulse in the carotid, but it's slow. What do we do? I think parents, when you look at them, you recognise that they know what's going on, they know that their child is dying, and you may feel like, what am I doing here? So when there's nothing to do, sometimes, Caroline, that's the hardest, isn't it?
So, well, practical stuff is, it gives us something to do, and I think that's probably the first thing I might do in this scenario, buy myself some time by doing some practical things. I might go and take a manual pulse, even if I'm not counting it. You know, an amazing palliative care professional I once worked with used to say, just go to the car and pretend you've got to get something. It buys you a little bit of time. Okay. But I think what's really useful, this is narrating what you're seeing. Family are asking you to help them. I wonder why they called an ambulance, because it sounds like they've got a team around them. Again, I think that probably speaks that 24/7 services aren't universally provided. That even when there is a 24/7 nursing service, they may live an hour away from the patient. Sure. And families may want someone much quicker. It might be in a panic, but in that 10 minutes between making the call and the paramedic coming, they've actually thought, no, we've done this, we've prepared for this, but they want a professional with them. I've cared for families where they've said, I can't give the last dose of medicine on my own. You know, I don't want to be the one that makes that decision. I need someone with me. I think I would narrate what I could see in front of me, because the family are asking, they're asking for your opinion, aren't they?
Yeah.
And actually, I suspect that if they wanted you to do something, they would have started some CPR themselves, or, you know. So I think I would say, I can see his breathing slowing down. This is often what we see when a child is dying. What's really important now is that he's comfortable. Do you think he's comfortable? If they say no, and say, do you have a plan for what to do? And I know as paramedics you can't give the medicine, but it may be in that brain fog. Probably this family have been managing their symptoms beautifully for this preceding 6 weeks, and suddenly in that frightening last moment, they just need you to say, looks like Oromorph's the next step. Do you want to go and get the Oromorph? If families say, oh, I think he looks really comfortable, and you think that too, reassure them of that, reiterate that. This is when the other bits of the plan might be really useful, you know, all that paper you've irritated, you waited for, and others, suddenly you see its value, you know, and it might be that it says call the priest, or that there's a nearby family member you can call, or actually having no professionals in the room is important to the family. And again, that curiosity. I think that he is dying, and I see here you've said you would just want it to be you and your husband. Shall I go and sit in the living room? You know, and even if they ask you to stay in the room, there's ways, aren't there, to make yourself small and quiet. And it's checking, you know, I see here that you that this professional has written the plan. Do you have a number to call them? Because even when there aren't decisions to make, that reassuring familiar voice, I mean, it's probably pretty nice for you as a paramedic to have an expert on the phone. So I think in those scenarios, we all love practical tasks, but the practical task here is the kindness, the compassion, the narrating what you're seeing, the reassuring family that the child is, and why don't you get into bed with them and give them a cuddle? You know, it can feel a bit child parent sometimes, because you feel like you're saying things that are so barn door obvious, but actually I think a parent, I can't even imagine it, but their vulnerability in that moment, they just want that parental guidance, and you as a professional giving permission. Exactly. I know I've sometimes been in situations where the paramedic's been able to verify the death, and that's been hugely important for the family, because it's meant perhaps they can have a transfer to the hospice to use their bereavement suite, or their cool room where the family can stay with the child, or perhaps the family, like we said, that scenario where there is a 24/7 contact, but they're 40 minutes away, and you can stay with the family until a trusted professional's arrived. And I know from family feedback how, you know, much that's appreciated. And you know, it sounds like a cliche, but sometimes doing nothing is absolutely the right thing to do. But that doesn't mean it has, in fact, it has huge value.
That sort of brings us well on to our next slide, if that's all right, Caroline, which is like talking about, in your years of experience, what you've heard from families, because you often meet with families after these events, don't you? And I just wondered what sort of things you hear and what sort of themes you hear.
I think overwhelming positivity. I've sometimes been in debriefs after a child's died, perhaps parts of the child death review process, or a professional debrief, and professionals have really over-examined themselves, and you can feel how badly maybe a professional feels, and actually families don't remember any of that. You know, I always say no one ever gets a thank you letter for prescribing something well. It's the small kindnesses that people remember. People appreciate that someone's there. People appreciate when families talk, when professionals talk to their child. I think that's incredibly important. And in that emergency moment, that's hard to remember, particularly I think when the child maybe looks so poorly in the bed. But that respect, that child as a young person, as an individual, is something that people tell me is incredibly important. I think there are some families that are really frequent users of the ambulance service, and you know, it's useful to them when perhaps people recognise their child, but we know that's not always possible, and that's not how we should be using the ambulance service. I think we have to recognise, families say how overwhelming it can be sometimes, because obviously a child's arrest can mean that several crews come to the and that's we want that, don't we? We won't want to stop that.
That's a normal response.
Normal response.
Yeah.
But actually, what that's like in a room, people have sometimes told me that they've picked up conflict between different paramedics about what the right thing to do is, and that's been really difficult. And I think every palliative care team or team in the hospital would really like that feedback, that perhaps a plan is not working.
Sure.
But I don't want to think the family have heard that at the time, because that is the kind of thing. If you're sitting in doubt as you're making the right decision, you want to know that everyone around you also believes the right decision. I think overwhelmingly people have talked about the kindness and compassion, how much they meant to them. And I think the bravest thing to be able to do in palliative care is just be present. And that's very different from what you usually asked to do in paramedics, isn't it? Which is like action.
It's a part of it.
Yeah, but that presence is, I know, is hugely appreciated.
I think my overall reflections on this is that the skills that the crews have, that pre-hospital staff have, fit this perfectly. You know, they're going to sort of vulnerable elderly people, or people who are palliative, or people who have complex needs, and the skills that you use with families around that, and the skills that you need for the children as well. It feels sometimes that that's different, because it's a child, and that you feel that you don't do this very often, and you feel uncertain and things. But my overall reflection was actually that the skills that you need about, like I think you were saying, compassionate curiosity, and sort of bringing people's wishes and about their death, to have the right sort of care around what they want at the time.
And I don't think palliative care is scary, but I don't think it's this super special set of skills. Actually, all the things that make us good health professionals, good paramedics, good nurses, are really transferable. Kindness, listening, appropriate action. We worry about doing the right thing, but we usually do. And we wouldn't with any patient. If we turn up to a patient with a broken arm, we're not going to intubate them. We're always decision making, aren't we?
Sure.
And it's that same set of skills. And as you say, these kind of communication skills are constantly needed in all sorts of scenarios. And certainly, I imagine there's massive parallels between adult palliative care and children's palliative care that can be used.
It's fascinating. I think so. We're thinking about sort of what life-limiting conditions are for the broad range of children, and how advanced care plans can vary throughout that and change, and how they can help us, the information that they hold, and then some case studies around how that practically can manifest with human beings, and family members and things and situations. So and
also, we didn't say this earlier, but that children with life-limiting illness can also have accidents, and they can have there can be safeguarding concerns, and in that case the PRP is almost slightly irrelevant, isn't it? Because what we're describing is you needing that good quality assessment of the child, and what do they need in that moment. And then it might be the PRP becomes more of a how-to guide to manage something quite specific. But there are, as we say, children with life-limiting illness who experience all different parts of life, and may need to access kind of paramedic care for a really wide range of.
And you haven't written on the PRP what to do when they fall over and break their wrist.
Yes.
So I just want to recognise that this is a really tricky subject, and it's important that if we've talked about things, or these conversations have triggered memories of jobs that you've done or experiences, that you just take some time to acknowledge that, and then decide whether or not you need to seek some support. It's normal for this to be a difficult thing to deal with, and a death of a child, no matter how well planned, or is never a good thing, and always a difficult thing to manage emotionally. I know that you will have support from, your employers from a psychological, emotional support point of view. But, it's important to recognise those feelings, act on them, and seek support if need be. We can be all guilty of just bottling things up and using a dark joke now and again to pretend that we've coped with it. But our point is to look after yourself, so please do. So that's the end of our webinar. Just wanted to thank you very much for taking time to listen to it. Hopefully it's been useful to us, and thank you, Caroline, for your expertise.